Good morning, everyone, and welcome. I know people are still joining the call, but we have a lot to cover off, so I will just get us started with some introductions. So my name is Melanie Brakovich, and I am the SAGE Product Manager with Stryker. I am very honored to be joined today on World Pressure Injury Prevention Day by Kathleen Vollman and Susan Salsbury, who will be spending the next hour with us to provide a high-level overview of the importance of protecting both patients and caregivers from harm. They will discuss evidence-based information on the prevention of pressure injuries, improving patient mobilization, and protecting our caregivers. Kathleen Vollman is a critical care clinical nurse specialist, educator, and consultant. She has published and lectured nationally and internationally on a variety of pulmonary, critical care, prevention of healthcare-acquired injuries, work culture, and professional nursing topics. Ms. Vollman serves as adjunct faculty for the CNS program at Michigan State University. She was inducted into the College of Critical Care Medicine in 2004, the American Academy of Nurses in 2009, and a fellow in the CNS Institute in 2019. She is focused on creating empowered work environments for nurses through her company, Advancing Nursing. Ms. Vollman also serves as financial director for the World Federation of Critical Care Nurses. Susan Salsbury is a workplace accommodation case manager at Ohio Health, where she was instrumental in the development of a transitional work program and is responsible for ongoing growth and implementation of services. She's a licensed occupational therapist, a certified disability management specialist, and a certified safe patient handling professional with over 40 years experience in clinical and employer-based environments. Ms. Salsbury has presented programs nationally on transitional work, ergonomics, and safe patient handling. She is a member of the American Occupational Therapy Association, the Ohio Occupational Therapy Association, and the Association of Safe Patient Handling Professionals. Ms. Salsbury serves as the education co-chair of the Central District Chapter of the Ohio Occupational Therapy Association and is a board member for the Association of Safe Patient Handling Professionals. A few quick notes before we get going. This will be an interactive session with our presenters, so please be sure to add any comments or questions to the group chat. I know that you're used to using the Q&A feature, but we have disabled it for this session, so you can direct everything to the chat box and I'll be monitoring it throughout the session. We'll try to get to as many questions as possible over the next hour. And we have a quick poll to get us started this morning, so let's see who's with us this morning. Please feel free to fill out the poll. And now I'm going to pass it over to Kathleen Vollman, who will be starting us off with her presentation, Intact Skin is In, Eliminating Pressure Injuries During Patient Mobilization.
Thanks, Melanie. So you guys go ahead and answer the poll. Also, if you could, I want to get the chat box warmed up a bit. If you could tell me where you're from. I'd like to see if we've got people from all across Canada. That would be awesome. And very happy to be here today for World Pressure Injury Day. Oh, Kitchener, not too far. I'm in Detroit. So we've got Ottawa and Quebec, Thunder Bay. Okay, Windsor, right next door. Halifax. Oh, we've got everybody represented. That's awesome. So go ahead and close the poll. And let's see who we have. So we've got a number of walk nurses, which is great. We have some unit managers, 31% frontline nurses, yay, and 22% nurse educators. And we have about 16% OT and PT. That's awesome. All righty, so let's go ahead and get started. As it was mentioned, I am going to talk about Intact Skin is In, and the focus of my presentation is really to look at where we're at and then look at the pressure injury side of things, and Susan will focus on the caregiver injury side of things. And so I do want to put disclosures forth. I am a subject matter expert for the American Hospital Association on pressure injury prevention, as well as a culture of safety. And I am sponsored by this presentation by Stryker. So I'm teaching, you're going to get objectives. identify the problems we're having with pressure injuries, mobility, safe handling, and the fact that they hang out in separate silos and making it difficult for us to collectively apply the evidence and make it easy for the frontline nurse to be able to do the right thing. And then we'll take a look at evidence-based strategies for reducing pressure and shear. Oh, we've got people from all over. No box for podiatrist. I apologize for that, Maria. So we have a podiatrist in the house. Whenever I talk about something as fundamental as taking care of the patient's skin, I like to take us back to the valuing piece of what our role is as professionals in managing and in really protecting our patients. Many of you are familiar with the phrase "do no harm." Our Institute for Healthcare Improvement in the United States has it as their tagline. I know Safer Healthcare Now in Canada has it as part of theirs. Our physician colleagues have it in their Hippocratic Oath. And if you go back to 1859, the two groups of people in the hospital were doctors and nurses. And then from the nursing perspective, the doctors split off into all those specialties and the nurses split off into a number of disciplines. So we all focus on this concept. It may seem a strange principle to enunciate that the very first requirement in a hospital is to do the sick no harm. And I would expand that into our homes, into our long-term care facilities. And so there's no question in my mind, our advocacy role equals safety for the patient. So let's look at how we get there, because one of the biggest challenges, and I was very fortunate to work with Joyce Black and Susan Salsbury in a publication on this, in the fact that we hang out in silos. And by hanging out in silos, what do I mean? Is we have caregiver safety initiative. We have a pressure injury prevention initiative. We have a mobility initiative. We have a fall initiative, and they come up with silo solutions. And those silo solutions then may not cross over and work together. And what I usually use as a perfect example of this, because I'm a critical care nurse by background, the use of lifts. In my perfect world, because that's where I live and I work really hard to get everybody hang out in my perfect world, is I would want a lift, not necessarily for in-bed mobility, but I would want a track going around my bed so I could walk a ventilator patient. I'd want a track going to the toilet. I'd want a track going out into the hallway, and I want a track around the nurse's station so that I could walk the patient safely, so that they wouldn't fall, that I wouldn't get hurt, and I would achieve mobilization. The challenge is the lifts came in with this concept of use them to turn or to move a patient 2 inches up in bed. And the likelihood that a critical care nurse is going to hook up 8 rings to make that happen goes down exponentially. So is it a comprehensive solution? So when we look at how well we're doing in these areas, I got to tell you, we're not doing well in the mobility world. We have a new walking dependent group, anywhere between 16 and 60% in our older hospitalized patients that require some type of aid for at least 30% of them are dependent 3 months out after discharge with some type of mobility aid. 65% of the patients have significant functional mobility decline within day 2 of being hospitalized. And when we look at mobility in the hospital itself, because all of this ripples as the patient moves along the continuum, there was a study looking at the frequency at which patients were any form of mobilization, and the patient spent a median time of 100% in the bed, 90%, 99% with little or no activity. And in the med surg area, the average is around 87% that they're spending time in bed. So we have a significant issue. So do we even achieve the minimum mobility standard? So get ready to use the chat box, because I want you to put an answer in here. There was a study. So this was a critical care study that examined over an 8-hour period. They observed for every 15 minutes to determine the percentage of patients that got turned Q2 hours. So and remember, both in Canada and the United States, we have 1-to-1 and 1-to-2 ratio. So that gives you an idea. So what I would like to ask is what percentage of patients got turned Q2 hours in that 8-hour period? What percentage do you think? Go ahead and put it in there. Natasha, 12%, Rebecca, 60%, Paula, 1, less than 25, 50. So we've got it sort of all over the place. Well, some of you got close to it. It was 2.7%. Yeah, we got a problem. And 50% of the patients didn't move in a 6 to 8 hour period. Now, there was a study that was repeated, a positioning prevalence study in the UK, where they have 1-to-1 nursing, but they also have chest physios, but they run their vents. And what they did was prevalence in ICUs for positioning over 2 days, and they measured it by hours. And the hour difference between turns was 4.8 hours with a standard deviation of 3.3. So that means some didn't move for 8 hours and some did get turned every 2. So we have an issue, and it's not just resource, it's also value structure. And we know the outcomes of early mobility programs are phenomenal, not just in the intensive care unit, but in the med-surg environment as well. Can higher staff amounts help? Not necessarily, Priscilla. Thank you for putting that question in. And I experienced that myself. It was really about changing the culture, because we were able to have the same staffing amount, but we changed the culture for the focus of some of these fundamental care practices, and we were able to successfully achieve it. Now, I know with COVID, our staffing challenges, I suspect you guys are experiencing the same thing that we are in the United States and all over the world. So this, I would say pre-pandemic. But remember, guys, if at first you don't succeed, you're running about average. So we've all got the challenge. Now, what about pressure injury harm? You're probably familiar with this data, but I'm going to put it out there. The international guidelines that were published, republished with revisions in 2019 show acute care between 0 and 12%, critical care between 3.3 and 53%. And when we look at the places where the pressure injuries are, again, this is acute care, sacrum and heel. So where does that tell me people are hanging out? They're hanging out in the bed with the head of the bed up, but on their back. So a challenge. I think the biggest factor is the staff resident ratio, specifically in nursing homes. I would say that's a challenge. So we have to find some creative strategies. One of the strategies that people have been using in the acute care is like creating out of the staff rotations of people that own the turning for that time period. So once in a shift, you own the Q2, Q3, Q4 hour kind of thing. So we have to get creative in that process. Costing out, this was a wonderful publication by an economic, I can never say that word, economist. And he's also the president of the National Pressure Injury Advisory Panel, very well received. The cost of a stage 1 to stage 2 is around $2,700. Stage 3 to stage 4 is about $71,000 to $127,000. Pneumonia prevention, head of the bed elevation is a problem. If we do the 30 degrees, you're right. But that's where we have to make sure that we're addressing shear through either a protective dressing or making sure that we have a type of turn and position system underneath them to take the hit on the skin from that perspective. The cost in Canada, where I could find in a publication, was around 44 to 99,000 or 90,000. And I did have a personal communication trying to identify some data in Canada, and this was preliminary data on prevalence from Alberta. 17% pressure injury and 75% of that was facility acquired, and that is in acute care. What about moisture related injury? 5,300 patients in 189 acute care facilities. This was done in the United States, but there's also been some European ones on looking at IAD. And one of the things that we know is with IAD, you have a 4 times greater risk for the development of pressure injury. And so what they found is roughly 46% of our patients are incontinent, and the majority of that incontinence is a combination of stool and urine. And in the European study, they found about 53% incontinence. So we know it's somewhere in between that, with an average IAD rate of 21%, with most of it being mild to moderate. 36% IAD rate in the intensive care unit. Now here's where we have the opportunity. 73% of it is facility acquired. So we have the capability. Can I have access to the form from ICU? Last slide of interventions according to RAS. Can you guys make sure you have that question? So I may ask for some better clarification on that. So when we put this all together, guys, we're looking at the outcomes. This is what we want to have happen to our patient: clean and protect, reduce pressure and shear, in bed and out of bed mobility. Here are the caregiver risks and with each of those activities, and Susan's going to delve into how we work and prevent that. And here are the patient risks for moisture, pressure, shear, friction, and then the risks of immobility. So putting it all together, looking at it. Now I'm going to handle the pressure shear side of things as a risk factor, and we're going to focus on sacrum and heels. So you probably very much recognize this Bible, the International Guidelines in 2019. Now, several guideline iterations before, they took out Q2 hour turning, and they said turn the patient as frequent as they need it based on the patient condition and the right surface underneath them. Now, the challenge is, so the reason why you still see 2 hours up there, and really in the long-term care, the data shows if you have a good mattress, you can go anywhere between 2 to 4 hours. The reason why I kept it is, think about it. I have a 600-bed hospital. I may have 200 nurses working, 100 nursing assistants. Each nurse makes an individual schedule up for their patient, and then shares that with the nursing assistant. The process variation on that is massive, and the likelihood that we're going to achieve what we need to goes down exponentially. We need to have the right surface. We're focusing on immersion, envelopment, and the microclimate as a part of the standards for the surface. We also need to make sure we turn with the right thing. So what I would like to ask, and this is almost a setup in the question, how many of you believe that pillows achieve offloading of the sacrum when you're turning somebody laterally? Go ahead and put that in there. I'm glad most of us got the no in there. The data shows it doesn't. And when I consult at, Laura, you're absolutely correct, for a few seconds and then it collapses. So when I consult, I literally get on the bed and I ask the nurses to position me with the pillows that they're using. And then I have them put the head of the bed up at 30 degrees, and then I have them put their hand in to see, I let them get a little fresh with me, to see if they can feel my sacrum. And guess what? They feel it. It isn't offloaded. So the biggest challenge I have, guys, is that we are asking people to achieve turning with ineffective methods. We need to be moving away from pillows and moving to wedges and making sure that it's not one big wedge, because that's likely going to sit on your sacrum, but you actually have 2 wedges so that you get true offloading taking place as a part of it. The other interesting thing that we do is the fact that we have these lovely surfaces that their goal is this immersion and envelopment, as well as microclimate management. But then we put a tight sheet on and we mess with their ability to immerse in it. So we have to pay attention to what we actually put on the bed and make sure it is loose enough that the patient gets the benefit. Now, many of you are probably using some type of prophylactic dressing in the sacral region and for device related, and the data is really good there. When we look at it, basically this is a meta-analysis, and what the data tells us is it favors the use of prophylactic dressings to reduce nasal bridge, and you can also see the benefit on the sacrum. Now, one of the things that I found to be very beneficial, because especially in the sacrum, these dressings can also be used for treatment, is to put a P or T on there, because if I have a P, that means I need to look at that underneath every shift. And if I have a T on it, it's being used for treatment, and I don't need to look as frequently as a part of it. The next thing, and I will share with you, Susan's going to talk more about this, but it's the concept of how we move. And the sad part is how we move somebody for in-bed mobility. The sad part is this is what is the most frequently done. And that concept of draw sheets and pillows, where we need to be looking at more of this concept of a breathable glide sheet that stays on the bed. I have wedges, and I also have a moisturizing type of wick away pad. So I'm looking, I do not want anything that has to go on and off the bed every single time I want to turn them, because that is basically not going to be used as a part of it. So when I look at how I'm going to effectively achieve the evidence as a part of this, I shared with you guys the value. That's the advocacy piece, the do no harm. Then you teach the skill and knowledge, but an absolutely critical component to this equation before you hold anybody accountable for practice is, do I have the right resources and systems to make the right thing happen for the patient? So what does it look like here? I want a breathable glide sheet that stays on the bed. I want 2 foam wedges. I want a microclimate. I want everything to breathe so I benefit my mattress. I want to reduce the layers of linen. And I want a wick away pad that wicks things away. And I want to protect the caregiver as I do this. And so when I look at data related to this, comparing the old way to the new way with a turn and position system, I can see in phase 1, so the groups were identical and they followed them throughout the ICU stay. Phase 1 with the draw sheets and pillows had a 28% incident of pressure injuries, and phase 2 had 0. With the turn and position system. And phase 1, 16 minutes to turn a patient, 16.5 minutes, standard deviation about 10 minutes. Yeah. Whereas with the turn and position system, not only do I achieve the outcome, but I also take less time to make it happen at about 4 minutes with a standard deviation of 2.5. So by using a turn and position system, does it improve compliance? So this was a multi-center clustered 3-arm randomized controlled trial. And they looked at the incidence of pressure injury and IAD with the first group where they tailored to individual risks and they used a turning and positioning system. The second, they used a turning and positioning system with routine turning and then usual care. And what did they find? Clearly, the groups that had the turn and position system had significantly less injury, and they were also significantly more compliant than usual care. 1, offload. 2, it achieves the turning. What about heels? The last part that I want to talk to you about. We want to assure a couple of things. So the way I look at an algorithm for heels is literally this concept of if that immobility, so immobility is my top, if that immobility is temporary, then they offload with pillows. And temporary means 8 to 12 hours. If it's going to likely extend beyond that, then I ask the question, is the patient agitated or not agitated? If they're agitated, they get a dressing on the heel because they're not going to keep the boot on, and I want to reduce the friction risk. But if they're not agitated, then they get a boot, and that boot suspends the heel, distributes the pressure up the calf, and also has something that prevents external rotation and pressure on the peroneal nerve, which contributes to plantar flexion contraction. So this was probably the most studied boot. This was done in the intensive care units. They compared this boot to pillows. And this boot also had prevention of that external rotation. And they, by day 2, 0 in the boot group, 41% of the patients were developing heel ulcers with pillows. They don't work. Now, what was fascinating about this study, they had a physical therapist involved in it that measured the plantar flexion contraction angle, that angle, and found that it improved some of the patient's angle or prevented any kind of drop from taking place. And so when you implement, so the reason why I like this study, it was implemented over time. They had an algorithm of when to use the boot appropriately. And what you saw was 5.8% reduction. That was where they started on the heels. Year 1 was 4.2, year 4 was 1.6. So what that tells me is my education, my algorithm, and the right evidence-based product achieved a 72% reduction. And so when we look at this across the board, what we're looking at is mobilizing the patient, protecting the skin while we do it, whether it's in bed or out of bed. And Susan's going to talk about protecting caregiver safety. And thank you very much. Yes, this PowerPoint will be available at the Stryker booth, the Stryker Sage booth, as part of the conference. So how do I make this happen? Advocacy, owning this, using Braden subscales, skin rounds, handoff communication, the right product for the right process, quarterly pressure injury, IAD and caregiver harm, and have those skin champions. And when I bring products in, making sure if they're complicated and they need to make sure they're being used correctly, having yearly competency as a part of it. So now I'm going to hand it back to Melanie so we can transition to Susan.
Thank you, Kathleen. That was an incredibly insightful presentation. Thank you so much for bringing those incidence rates to our attention. They were quite alarming. So I appreciate you providing such comprehensive recommendations to reducing those risk factors for pressure injuries. So now I would like to welcome Susan Salsbury, who will be speaking to patient handling with her presentation, Safe Patient Handling, Reducing Risk Risk through Evidence-Based Interventions. Susan, it looks like you got your screen shared, so I'll pass it over.
Good morning, everyone. We're excited that you're here today. This is my passion. Kathleen and I have had the pleasure of working collaboratively and hoping to share some new fun facts and sharing the evidence about how we really can protect patients, but also protect our healthcare workers. Next slide. Let's see, next slide, just enter. There we go. So I am on the disclosure, I am on the speaker bureau for Stryker Sage Business. Again, evidence-based, we're going to talk about ergonomic risk factors for patient handling injuries. We're going to identify strategies and technologies for safe patient handling and mobility. And then we're really going to look at that relationship between early mobility, safe patient handling, fall prevention, and pressure injury prevention. So really looking, as Kathleen had spoken to, not having the silos, but really looking at an integrated, comprehensive program that addresses all. Again, we talk about that whole culture of safety. We know mobility is medicine. We know if we mobilize early, we're going to decrease the risk of patient falls. We're going to decrease the risk of pressure injuries, and we're going to decrease the risk of patient handling injuries if we use the right technology, and then we're going to improve patient outcomes. So really, looking at the focus of not siloing, but really integrating so that we're all working collaboratively to achieve the same best practices. So what is ergonomics? Ergonomics is really looking at the work, the worker, and the workplace, and looking at how we can provide a workplace design to ensure the biomechanical, physiological, and psychosocial limits of people are not exceeded. Okay, and this comes from the Fiji guidelines, which again looks at evidence-based best practices for when you're doing renovation or where you're doing new building, but really looking at that relationship between the work that's being performed and the environment in which it is performed. So what are ergonomic risk factors for patient handling injuries? And when we look at this, we really look at 4 ergonomic risk factors. The first one is force or exertion. And again, please use that chat box. What's the most physically demanding part of your job as a healthcare practitioner? What requires exertion or force? Put it in the chat box for me. And Melanie, I'm going to have to refer to you to let me know what they're throwing in there. Let's see. Okay.
No, we don't have any response.
Yeah, I can, Susan.
Thanks, Kathleen. If you can tell me, what are people identifying as exertion and physically demanding parts of the job? What's the hardest part of the job for you?
Go ahead, guys, put it in the chat box. Frequent repositioning.
Absolutely. That's one of the most physically demanding parts. Any other parts of your job that require force or exertion?
Hygiene.
Absolutely.
Thanks, Priscilla. Nancy, patient that resists turning, transferring, patient mobility transfers, toileting, moving beds, stretchers, repositioning, and length of time standing at the bedside, dressing spinal cord injury patients.
You guys are on a roll. That's a great, awesome.
Yeah.
How about repetition? When we look at ergonomic risk factors, we look at the force, the exertion, repetition. What do you do all day long in a 12-hour shift, all day or all night? What are those nursing healthcare worker tasks that you do repetitively throughout the day?
Love it, Laura, charting.
Can't forget the office ergonomics as well.
The bariatric, bariatric personal care evaluation of patients, application of Coban.
Oh, that can be very, very repetitive. Any other thoughts on repetitive tasks?
Bending, lifting, feeding.
And then we look at postures. We look at awkward postures or static postures. When you think of your healthcare work environment, what are those awkward postures that you do throughout your shift?
Oh, this is a great one. Foot care at the bedside.
Oh, absolutely.
Healing.
Even if you raise the bed upright, a lot of times you're going to get in an awkward posture if you're taking
debridement, bedside debridement.
Yep.
Assessing heel injury on patients lying in bed. Intermittent casting. Oh, you guys are awesome. Slouching.
That would never happen, right? And then the last risk factor is duration of exposure. How many of you have worked 8-hour shifts, 12-hour shifts? How many of you have worked for more than 5 years, more than 10 years, more than 15 years? Who's my most wisdom worker in the audience? Who has been working direct patient care for the longest, Kathleen? What do we have there?
So we got 38 years, 32, 30, 12, 20, 36, 13, 27. So I think 38 is the longest so far.
So far, okay. So
Annette at 43.
All right, give it up for Annette. So these factors are cumulative, okay? So when you think about if you think about heart disease risk factors, again, ergonomic risk factors, those are the issues that happen in the workplace that can directly impact your risk for a patient handling injury or a work-related musculoskeletal injury. So what is a work-related musculoskeletal injury? Those are those injuries to your muscles, nerves, tendons, joints, cartilage, and intervertebral discs. These are where the work environment absolutely contributes to the condition. It's not your slip, trips, or falls, or needle sticks. Those can still be reportable injuries, but these are those musculoskeletal injuries. And if I would ask you in the audience, how many of you have experienced a musculoskeletal injury, a neck strain, a rotator cuff strain, a low back strain, or plantar fasciitis can sometimes be work related as well.
So we've got Teresa trying to recover from one right now. Sorry to hear that. Heel spurs, both feet. Laura is also recovering from one right now. So you've got them live. Low back pain.
Yeah. Healthcare is a hazardous occupation. None of us thought about that when we got into it, but it truly is. So again, we want to look at what we can do to protect you as well as taking care of your patients. Injury statistics, you know, healthcare is a hazardous occupation. In 2016, the major source of injuries to registered nurses was handling person other than the injured or ill worker, with 83,000 cases. In 2016, 51% of all injuries and illnesses were resulted in sprains, strains, or tears, which required a median of 7 days away from work. And the injuries occurred at a rate of 53 cases per 10,000 full-time workers. So again, significantly greater than any other healthcare worker. Incidents and costs, this is from FAAN, which is an insurance actuary that really takes a look at comparing the costs related to musculoskeletal injuries. And you can see where your backs and your shoulders make up 70% of the incidents and costs related to patient handling or musculoskeletal injuries, with the shoulder racking in at 13,400 on average, and backs at 8,700 per average. And again, why do you think a shoulder's more expensive than a back? It's a more complex joint. I'm sure some of you have experienced rotator cuffs and long rehab. So really looking at what we can do to prevent these rather than having to rehab them. Would you agree with the statement that healthcare is the only industry that thinks 100 pounds is light? Right? Any other industry, you have your dollies, your rollers, forklifts, and your power jacks to move your product. What do we have in healthcare? We have a sheet, or we use a chucks to move a patient. Could you think of any other industry that would say, hey, there's 200 pounds on the ground, let's go pick it up, right? Nurses and health nurse assistants have the highest rate of non-occupational injuries and illnesses of any industry sector. And there's research out there that documents nurses lift an average of 1.8 tons per shift. 1.8 tons per shift. That's like lifting a small, moderate-sized vehicle. It's crazy. The American Nurse Association did a survey back in 2013. 80% of nurses work despite experiencing musculoskeletal pain. 62% of nurses are concerned about developing a disabling musculoskeletal injury. And 56% of nurses say that their pain is made worse by their job. Patients of size. Is our patient population getting larger? Prevalence of obesity was 42.4% in 2017 to 2018. I want to, in your chat, what's the heaviest patient that you have cared for? Put it in that chat. Who's got the heaviest patient that they've cared for?
So we got a 650 pound.
Okay, 650.
I love what Maria said. Even the chart is heavy when you have, we have 1,000 pound when you have shoulder problems.
Yeah. 1,000 pounds.
Lee said 1,000 pounds.
And how did you care for that patient of size, 1,000 pound patient? Because again, we were healthcare practitioners. We want to honor the dignity and worth of every patient. But if we have a patient of size, we need to have the tools to be able to care for that patient of size, like Kathleen addressed to earlier. I'm curious, the person who wrote about the 1,000 pound patient, what did you do to mobilize that patient, or how did you mobilize that patient?
Well, Lee said it was a huge learning curve for us. He was young.
Yeah. And morbid obesity is a healthcare epidemic, and we need to really look making sure that we have the tools to care for our bariatric patients with dignity and respect. So how do these low back disorders happen? You experience those biomechanical forces from force, exertion, repetition, and awkward postures. And those biomechanical forces cause microfractures to the end plates of the disc. Well, our spinal nerves don't go to the inside of the disc. So in your bending, reaching, twisting, boosting, and turning throughout your day, you may be experiencing microfractures to the end plates of your disc and not even know it. Well, then those microfractures cause scar tissue, and scar tissue leads to nutrient deficiency, which leads to disc degeneration, which leads to decreased tolerance and capacity. So you may be experiencing those microfractures and be asymptomatic until it's finally the last straw that causes the debilitating back pain.
Susan, just to let you know, Lee did respond. The hospital bought a bed that allowed us to sit him up without standing him up. And then Paula said they have an ergonomic bed which converts to a chair when being washed and mobilized.
Fabulous. And that's an engineering control. That's really looking at what tools can we bring into the environment to make it safer for us as healthcare practitioners, and then again, taking care of that patient. So Bill Maris is a researcher at the Ohio State University in Columbus, Ohio, and he's one of the first leaders in looking at the inherent risks with moving and transferring patients. He's got this amazing biodynamic lab where he puts an exoskeleton on people and measures the forces from lifting, moving, pushing, and pulling. And what he found is that we have more tolerance for straight up and down lifting, the compression forces from lifting something close to your body straight up and down. We can tolerate 3,400 to 64 Newton's limit. But in the anterior and posterior, forward and backing, and lateral side to side movement, we have a much lower biomechanical tolerance, 1,000-pound limit. And when you think about patient handling, we're not typically lifting our patients straight up and down, right? We're forward reaching to move them, and then we're boosting side to side. So it's those anterior, posterior, and lateral shearing movements that we are biomechanically unable to do. There are limits to what a human being can do. We're human beings, not human doings. So I have a polling question for you, if you can pull that up for me. So what is the evidence-based maximum amount of weight that any healthcare worker should lift in a controlled environment? And the survey says, and that's outstanding. So 59% of you are spot on. 35 pounds or 15.8 kilograms, if you're using kilograms in Canada. 35 pounds, my friend. That is on a 200-pound patient. That is the weight of their leg. So, and if we go to it's just crazy, but how many of us would think nothing? Oh, I have a 100-pound patient. I've got a lightweight. That's easy. How many people, say, oh, I don't need help with that person. She's only 150 pounds. But the recommended evidence-based maximum amount of weight that any healthcare worker should safely lift in a controlled environment is 35 pounds. And this work was done by Tom Waters. And that's when the weight lifted is estimated, the patient's cooperative, and the lift is smooth and slow. And that's based on the NIOSH, Institute of Occupational Safety and Health. And Canada has your own occupational safety and health. And I went to the webpage there, and it's fabulous. It has a tremendous amount of resources and they have a whole component on your safe patient handling and patient safety. So if you're not familiar with that particular website, I would encourage you to go there and look at it. It's very similar.
Susan, Laura had a question.
Sure.
How is that realistic, the 35-pound expectation, given the average weight of a grown human adult?
Laura, that
is also stable weight, not somebody moving around.
Laura, thank you for that question. That's an absolutely amazing question. So what we need to know is really look at evidence-based practice. How many of you nurses remember when you used to recap needles? Do we do it anymore?
Nope. Yeah.
Nope. Because we know it's inherently unsafe for a bloodborne pathogen exposure if you recap a needle. How many of you remember when we didn't gown and glove and mask when we went into patient rooms? I've been a therapist 40 years. I thought nothing of, just going on into that respiratory isolation. But now, and especially with COVID, we know the importance of the respiratory protection PPE. How many of you remember when we didn't foam in and foam out every time, all the time? I'm so old. I remember when we would put, where mamas would carry their babies in the front seat of the car without using a car seat. And I remember sitting in the back of the paneled station wagon with no safety belt, pulling on for the truckers.
Susan, you'll love this one. Priscilla says, remember smoking in hospitals.
Oh my God, that's awesome. Thank you, Priscilla. So when we know something changes with evidence-based practice, when we learn, as we're adult learners, that something changes and it's not safe, we need to change our practice. And you may say, 35 pounds, oh my God, that's every patient all the time. Well, yeah, maybe it is. And that's where we look at that culture of safety. How are we mobilizing safely? What tools are we using? What can we do for in-bed mobility? What can we do for out-of-bed mobility? And looking at the technologies that are available for use. They initially did the research, that most adults can lift a 51-pound box from mid-body to shoulder with good handles without exceeding the compression forces for incurring a work-related or a disc disease, and back injury. But Tom Waters said patients are different than boxes. And how's a patient different than a box? Chat me up. How are patients different than boxes? Do they have handles?
They move.
They move. And do they have handles? Do they have those love handles?
They resist.
They resist. They're unpredictable.
They're bulkier.
Yeah. And again, you spoke to that earlier as well, Kathleen. So it's really looking at, we know the evidence is out there. There's over 20 years of evidence that studies that have shown that is inherently unsafe to manually move patients. So we need to change our practice so that our healthcare workers don't become the patients, right? Average age of nurses in the US is 48 to 50. Nearly half of nurses are over 50. And if we want to keep our wisdom workers at the bedside, we've got to improve the ergonomic environment, because we don't want to lose that skill set. This is my favorite study. Now, I don't know about in Canada, but in the US, they will give our sanitation workers automated trash trucks to lift up the trash because they don't want them to injure their back. But how does this picture in the OR resonate? How many people? Just give me a couple more people. We'll just push. 1, 2, 3, push, right? Resonate with anyone?
Yeah, so Maria said same here on the trash can.
Yeah. So we really need to look at how we can do that to make it better. So manual patient handling, that's what you're currently doing, lifting, moving, sliding without mechanical assistance, safe patient handling. It's evidence-based. It's looking at reducing the risk to caregiver, looks at an assessment, use of equipment, patient assessment, algorithms, peer safety leaders, and after action reviews. And Audrey Nelson from the Tampa VA really was instrumental in the early parts in 2006. And since the VA did it, all those algorithms are available for you. Why safe patient handling? Improves quality of care, improves mobility, reduces the risk of pressure injury, and improves patient satisfaction. And what's the benefit to you as healthcare workers? Wouldn't you love to have more energy at the end of the day? We want to decrease your injury rates. We want to keep the wisdom workers at the bedside, and we want to decrease workers' compensation costs. And again, this comes from the Facility Guidelines Institute 2018. ANA standard.
So
Yes,
Susan, there was a comment on here, in long-term care, we don't have lift policies.
And again, that can vary from acute care, long-term care, home care, and really safe patient handling should be across the continuum of care, from the very beginning all the way across the continuum of care. It's a journey. It's a marathon. It's not a sprint, and we're not where we need to be yet. And that's, we need to advocate, like Kathleen said, advocating for our patients as well as our healthcare professionals. This is the ANA Interprofessional Standards of Care, and this initially came out in 2013, and it was just revised and will be, it was just shared at the Magnet Conference in the US, and so it will be available. But it really looks at, if to have a comprehensive program, what's the first thing you want to do? Establish a culture of safety. And then it talks about how to implement it, how to use ergonomic designs, how to select and install your technology, looking at a system for education, training, and maintaining competence, integrating that patient-centered safe patient handling assessment into the patient-centered plan of care, using safe patient handling as a reasonable accommodation with return to work, and then looking at an evaluation, a comprehensive evaluation for what's going to look at. When we look at evidence-based approach for safe patient handling, again, administrative controls, that's your leadership, your budget, your policy, engineering controls, your equipment, maintenance and storage, and behavioral controls, your education, your peer coaching, and then your whiteboard communication within the room. Again, how do you communicate the patient's level of mobility? This was a funny story. One of the safe patient handling companies was an easy way lift. And so someone put that the patient was an easy lift, not thinking that the patient, they wanted them to use the easy lift, floor-based lift. They thought the patient was an EASY lift. So you can imagine really looking at that communication so that we're speaking the same language. Our organization, we labeled our patient handling program, we called it SMART Moves, Safe Mobility and Responsible Transfers. So really looking at, instead of saying, I need lift assistance, I need a SMART move in 2020. So it's really, again, maintaining the dignity and worth of that patient. We know mobility is medicine. What happens if we don't move patients? We have illness, immobility, and weakness. No, we want to mobilize. You can still be ill, but we want to maintain the functional independence. And Kathleen spoke to that again earlier, really looking at the relationship between mobility, maintaining the importance of early mobility, safe mobility, and how it's all integrated. So what happens when our patients don't move? What are some of the risks? Chat it up. What are some of the risks when our patients don't move?
So Susan, just want to give you, we've got about 7-8 minutes left.
Oh, then I'm going to go faster. So just, this is our favorite topic, guys, and we just want to share and share and share. So again, delirium, pressure injuries, increased risks of falls, functional declines. There are mobility assessments that can give the bedside nurse opportunity to assess the patient's mobility so you don't wait on therapy. In-bed mobility options, specialty beds, friction-reducing slide sheets, air technologies, ceiling lifts, out-of-bed mobility, ceiling lifts, floor-based lifts, walking harnesses, powered stand assist device, non-powered stand aids, transfer boards. We were a beta site test for the use of the AirTap technology, significantly improved associate satisfaction and compliance, and much positive response to how it improved the mobilization of those critically ill patients in ICUs. Ceiling lifts require less force. It's a matter of just getting them and implementing them. Seated positioning challenge, again, great study done by Guy Fergala about the force in terms of repositioning patients in chairs. And again, if we look at early mobility, caregiver safety, skin safety, and fall prevention, we're going to improve patient outcomes and keep people safe. So the risks, what are the solutions? Take it away. Sorry, guys. It's just like, this is our, Kathleen and I could speak for days on this. So questions.
Very true, we could. So we'd like the opportunity now, guys, in the chat box to have you ask any questions. There was a question early on. What about keeping residents independent? And I think that is a critical component that we build the muscle strength, but also make sure they're safe while they're doing the mobility practice.
And we're really working with therapists to incorporate safe patient handling technologies into their practice. And we found there's, again, many studies out there that show that the patients can improve their function and the therapists can do more when they're not relying on having to manually hold that patient up.
Right. So Priscilla asked, how can we advocate for safety in our organizations? One of the strategies is literally, and I know this sounds, please, but data collection, understanding the magnitude of the problem to be able to then present that data both on worker safety and patient to be able to make the right case to your organization about a safety culture.
Right. in my current role as a quality specialist, I'm looking at the NDNQI data. So I'm looking at the CAUTIs, I'm looking at the CLAPSIs, I'm looking at the HAPPIs, and I'm looking at patient falls, and being able to, again, integrate all of those key components and how they impact patient outcomes. That's data drives outcomes. Data drives that safety culture.
It does. So there were a couple, Maria and Jennifer asked if we could show the boot again. I would recommend, we probably don't have time for that. I apologize. But what I would do is go to the Stryker booth because that's where the evidence-based product, it's called the Prevalon boot. And they will be able to talk to you more about that device. We have another question. What are your thoughts on the use of convoluted foam heel protectors and posies that do not travel up the calf? Anytime you have pressure and you don't distribute that pressure, it has a tendency to put the other components of the body at risk. It's why we don't use donuts anymore. So distributing that pressure up the calf is critical. The other component about foam heel protectors, just straight foam heel that don't elevate the heel, I'm just going to be flat out honest with you. They need to go bye-bye. Because they fake you out. Now, the only thing they really do is prevent shear and friction injury, but a dressing can do that. But because we have this big fluffy thing on, it makes us feel like we're protecting the heel, but the heel was not meant to lay on any surface, so it absolutely has to be elevated. I've used several and found that the Prevalon, so Laura Laura has used the device we presented the research on and found it to be superior. Which dressing would you recommend? There's two that have the most research, the Mepilex dressing and the Alleven Life for pressure injury protective dressings. I normally don't mention products, but because you specifically asked, I'm going to bring it up. Thank you for the information. Our hospital uses these all the time. And I know the fluffies, they use the fluffies, and I know they're not good. Yeah. So, and one of the things to really, and this is where using, so one of the things that I've discovered, guys, is we're practicing using evidence-based practices with non-evidence-based products.
Mm-hmm.
And so we're not getting the outcomes that we are expecting to see by this work, like turning with pillows,
Mm-hmm.
like a heel fluffy versus a heel boot that elevates the heel. So
with the chucks versus using air
the
technology.
chucks versus a true wick away pad. So those create, it creates a significant challenge in every place. A lot of places that I'm going to, it's my new statement because I'm finding it a significant challenge. The staff are working hard, trying to do the right thing. Priscilla said, what would you recommend for superficial coccyx wound? By the way, superficial coccyx wound, you can use those two dressings I just talked about. They have a pressure protection as well as a shear protection.
I know we're coming to the end, and I hope they'll be sharing our contact information. This is my passion. I would be happy if you have additional questions. I know Kathleen feels the same way. Reach out to me. Contact me via email. We're on the same journey. We are on the same journey.
When you get the slides at the booth, guys, you will have our email addresses.
Yeah.
So if you want to reach out, and Teresa, thank you I appreciate the silo perspective. We need to collaborate, and that's a perfect way to end this, because that's exactly what we need to do, is collaborate to make the right thing happen for our patients and ourselves.
Absolutely.
In creating that safety culture. So thank you
all
very much, everyone.
We appreciate your participation this morning.
Thank
Bye-bye.
you, Susan. Just before we drop off, the slides are available in the Stryker booth under the red documents tab. You can download those, and Melinda, our medical education program manager, and myself will be in the booth the rest of the day. So thank you, Kathleen and Susan, and thank you, Wounds Canada, for the opportunity to partner and be a part of World Pressure Injury Prevention Day. Enjoy your day.
Have
Thank
a
you
great
all.
day,
Have
everyone.
a great rest of your day. Bye now.
Bye-bye.